Yeah.
Okay, should be recording now. All right, thanks everyone for coming. We'll just run through pathology first. First, some presenting complaints. So I think actually Gavin and Alina have gone through most of them, so we'll skip through those really quickly, and then I'll go through all the GI pathology, and then we'll move on to clin skills. And then let me know if you'd like to do nutrition. Great. There we go. Okay, constipation. So as mentioned before, it's defined as passing stools less than twice a week, or it just depends on like stool consistency, or how much the patient has to strain for it to happen. In terms of etiology, there's obviously no point memorizing all of these, but if you can understand how some of them work, it would really help you. So for example, irritable bowel syndrome, people commonly complain of diarrhea or constipation, which is relieved with defecation. Opioids is a big one, so I'll go through that a little bit, but as well as like fiber intake. And dehydration would be some of the more important ones, as well as hypothyroidism, I think. Complications can include anal fissures, which are basically just cuts, and you would treat the underlying cause, as mentioned by Gavin before. So opioid-induced constipation is quite common, and it is more iatrogenic, and that's why you have to know a bit more about it. I'd say just know that you can kind of reverse it via naloxone by blocking the gut mu receptors. Diarrhea, loose consistency stools or liquid stools, usually more than 3 times a day. And this is important. So osmotic, secretory, exudative, and inflammatory are kind of the 4 big areas that they want you to know about. So osmotic is when you actually have things left in the lumen of your bowel, and then water essentially just moves into the lumen via osmosis. So this might happen, for example, if you had lactose intolerance and you had all that extra lactose being broken down in the bowel, hence drawing water in. Secretory is similar, but it's the bowel wall actually just secreting more stuff. Exudative is the actual cell of the bowel wall leaking. So your enterocytes are kind of leaking their contents into the lumen rather than secreting things. And inflammatory, like all other inflammatory disorders, you get a lot of leaky cells as well. Acute defined usually as within 2 weeks, and chronic over 2 weeks. So when it's acute, it's usually infection by all of the agents Gavin mentioned prior, or chronic are usually due to these big 4. Lactose intolerance, celiac disease, inflammatory bowel disease, and irritable bowel syndrome. So remember, it's IBD and IBS. Inflammatory for disease, I usually think, because it's a bit more serious, it's a disease rather than irritable, which doesn't seem as serious, which is a syndrome. Yep, I'd say out of this slide, the most important thing is probably dehydration and electrolyte imbalances that diarrhea can cause. So if you do see a patient who vomits a lot or is having a lot of diarrhea, you have to monitor their fluid status, their electrolytes, and make sure that they're not losing too much of either. In particular, hyperkalemia is very high yield in second year because it can lead to dangerous heart rhythms, alongside things like magnesium. So usually you test to find the etiology via stool sampling, colonoscopy, which is when they stick kind of like this long tube with a camera on its end up the butt, and essentially it can travel all the way past the sigmoid colon, up the descending, across the transverse, and down the ascending, and then it kind of has to stop there because of the ileocecal valve. And then you can test for specific things like lactose intolerance, celiac disease, or IBD. And you'd usually treat the underlying cause. Vomiting, also covered. I guess key point here is you should know the neurotransmitters. So acetylcholine acting on M receptors, histamine acting on H1 receptors, serotonin acting on 5-HT receptors, and dopamine on D receptors. And then you can just kind of remember what receptors are in each area and hence what targets what. Yes. Gastroparesis, I think I popped this in the wrong slide, but it's basically just stomach paralysis, very low yield, but it's when you would use a motility stimulating drug, essentially. Dysphagia, difficulty swallowing, can be caused by diseases of the mouth, tongue, or salivary glands. Neurovascular disorders, as well as outpouchings on the pharyngeal or esophageal wall where food can essentially get caught. And usually the patient will come in and complain about like, oh, I feel something sticking in my throat or my chest, or my food's just not going down. And you can basically search for the cause using a barium swallow. And basically it's radio-opaque barium, and then you take an x-ray and you can see all the white maybe stopping somewhere where there could be a stricture or a blockage. Or you can do esophageal manometry and measure the pressure, and you treat the underlying cause, as with all of these. Achalasia, which is a neuromuscular disorder, is when the lower esophageal sphincter by your stomach, which remember is a functional sphincter, isn't fully working and doesn't fully relax. The main cause is diabetes. And usually you can keep it open with something like a balloon so that food can keep going down. Xerostomia is dry mouth, usually from insufficient salivation, and this can be caused by dehydration, shock, drugs, things like that. I think the main takeaway could be the diagnosis. So you can essentially give them 5% citric acid, which apparently tastes horrendous, and then measure the saliva produced. Or you can do a dry cracker test where you get them to eat a dry cracker and they find a lot of difficulty swallowing. And you can treat that with a muscarinic agonist, so something that enhances the PNS because of rest and digest, and hence give you more salivation from your salivary glands. Ptyalism is excessive salivation or drooling, and you can do the opposite. So you can give saltropine, which is a muscarinic antagonist. Now, jaundice. So jaundice is a yellow discoloration of the skin caused by excess bilirubin. And you might remember from our last session that bilirubin is released because of red blood cell metabolism. And essentially, it's because it's broken down. You're releasing all this heme. And usually it should be conjugated by the liver and then excreted. And so you would get buildup mainly in 3 ways, and they want you to know these pretty well. Prehepatic is before it reaches the liver. And so this can be caused by an excess of bilirubin. So you're releasing a lot more than you usually would. And because you're releasing it, it's not yet conjugated by the liver because it hasn't reached the liver yet, so it's unconjugated bilirubin. And this is most commonly caused by hemolytic anemia, and then all these other heme diseases essentially can basically cause red cell lysis, and hence hemolytic anemia again. Intrahepatic is when there's an issue with the liver itself. So it's a liver conjugation issue, usually caused by liver damage. So the big things that cause liver damage, 1 is alcohol, 2 is hepatitis, so like the viruses, as well as drugs. And then post-hepatic is obstructive. And this is when something is blocking the outflow from the liver, from the bile ducts. So that can be caused by gallstones or a mass or an ulcer, things like that, which causes things to backflow into the liver, and hence it can't do its job properly, essentially. So what do you see? You see yellow skin and sclera, which is your eye. You see high bilirubin in the blood, You get pruritus, which is an itch, and you also get pale stools or dark urine in obstructive jaundice only. So that's the post-hepatic causes. You wouldn't get those in the intrahepatic or the prehepatic because it's essentially caused by blockage of that duct. The acute abdomen, I was pretty confused about this when I was first learning about this, but it's essentially just if you are sitting in the ED, someone coming into the emergency department with usually pretty severe abdominal pain. And that can be due to a couple of things, depending on where the pain is, depending on their history, and it's usually pretty urgent and quite a rapid onset. So that's your acute abdomen. It's presenting complaint. 20% of all emergency department presentations are abdominal pain. So this is pretty important. And 30%, so about 1/3, need admission and surgery. So of these, there are quite a few causes, but the life-threatening ones are an abdominal aortic aneurysm rupture, pancreatitis, or a perforation of the gut. So a peptic ulcer could perforate your stomach or your duodenum, and a diverticular could perforate, I'll talk about this a bit later, but in your sigmoid colon usually. Moderate causes would be appendicitis, cholecystitis, sigmoid diverticulitis, and all of these things basically need surgery pretty quick. So they'd be sent and prepared for surgery. And then self-limiting things might be gastroenteritis, so that's your tummy bug, and lymphadenitis. So when you have a patient come in with acute abdomen, you want to take a pain history. You can do your WWQQA, BICA, or you can do ESRS-CoA, depending on what suits you. But looking at the site, if it's paired viscera, so something like your kidneys, pain will appear on skin of the same side. And if it's unpaired, so something like the liver, for example, it's often affecting or giving you pain over the midline. You'll have to ask where it radiates, how severe it is, the character. So is it visceral, which is usually dull, not too bad, or is it somatic, which is a lot more severe, for example, and it's localized. And occurrence is instantaneous. For example, a perforation is a crescendo, like pancreatitis. Is it colicky, which essentially is like someone going constantly, like in, out. So it's something that's really repetitive. That's usually due to some kind of obstruction. So you're thinking of stone in your ureters, or you're thinking a stone in your bile duct, or you're thinking like a small bowel obstruction, something like that. Is it associated with food, etc., and associated features? And then you'd ask about like associated symptoms. So you should know your 9 areas of your abdomen. This is really important because it not only tells you what it could be, but also in your OSCE, they'll probably get you to kind of like say it out loud. Essentially, you can remember it pretty easily because it's named according to what's there. So epigastric is it's above your belly button or your umbilicus. And that's why it's epigastric. It's above your stomach. Your stomach is there. Hypochondriac, chondro means kind of like your ribs, right? So that's right under your ribs. Hypo usually meaning under. So your left and right hypochondrium. Oops. Lumbar on the sides. And then iliac, or like iliac fossa on the bottom right and left corners. And that's because your bone, your ilium, is there. And then we usually call this one suprapubic because it's right above your pubic bone. So I realize that these pictures might be a little bit hard to see, but this is pretty high yield because when you ask, oh, where is your tummy pain? Essentially most things, if you can get the area down, you can limit your diagnosis to only a couple of things. So some of the important ones are if you get appendicitis, you get kind of a dull pain around your belly button or umbilicus, and then it migrates to your right iliac fossa. And then it becomes really bad. People start vomiting, and then they come into ED. And they're like, wow, I had this migration from here to here. And that's basically because it's gone. Appendicitis is like inflammation of your appendix. And it's gone from your visceral to your parietal peritoneum, causing visceral midline to parietal pain here, which is a lot sharper. Something like cholecystitis, you'll have it in your right upper quadrant, and then it might irritate the diaphragm and hence refer up to your shoulder blade, or it might, to your scapular tip. Pancreatitis, it's very epigastric, and then it radiates all the way to the back because it's retroperitoneal, and that's like 10 out of 10 pain. People are horrendously sick. Pyelonephritis, or renal or ureteric colic, like a renal stone, will have loin to groin pain. So you can kind of see in this one, it's going from your back, loin, all the way to groin. And that's literally because the kidneys are here. It follows the ureters down all the way to the bladder. So that's really easy to remember. You can see the diaphragm one right here, the gallbladder one right here, and the liver. Between the liver and the gallbladder, you can't really tell. And most things are actually where they are. Like the appendix is here, the stomach is here, the pancreas is here, the spleen is here. So it's actually pretty self-explanatory. Brilliant. Next. So we're on to pathology now. Great. One of the ICLs you get this year is obesity. And that's defined as the abnormal or excessive fat accumulation that presents a risk to health. So 2/3 of Australians are overweight or obese, and ATSI has twice the prevalence. Usually you diagnose this, or you kind of measure the BMI, the waist circumference, and then you might take some other measurements. So in terms of BMI, obviously it's not the best way to measure things, because it's often athletes or something like that, but take an educated guess, see if they're an athlete or not, and it's weight over height squared, your height in meters, so don't do that in centimeters. So if they're under 18.5, then they're underweight, and then between 18.5 to 25 is a normal weight. Above 25 you start getting issues, so that's when you're overweight. If you're above 30, then it's obese class 1, 35 class 2, 40 class 3. And then waist circumference, which is measured at the level of the iliac crest. So if you put your hands on your hips right now, where it touches the highest point of your hips, kind of, that's your iliac crest. So that's where you would measure the waist circumference around them. For women, that should be above 88 centimeters, and for men above 102. And so if it's above these measures, then they're considered obese, essentially. And then you run investigations for secondary causes. So you take a history, ask about their lifestyle, do a cardiac exam, looking for things like hypertension, do a thyroid exam, because hypothyroidism, and your thyroid is in charge of your metabolism. So when you have hypothyroid, you have a lower metabolism, you tend to gain weight. And then you look for complications, so things like diabetes, things like hyperlipidemia, so too much fat in your circulation, and do some liver function tests because of fatty liver. In terms of physiology, weight gain is caused by energy input over energy output. And your energy output is your basal metabolic rate. So that's your metabolism when you're lying down doing absolutely nothing, and related mostly to lean mass, so your muscle mass. Plus your non-exercise activity thermogenesis. And that's just like you walking to the fridge, you getting out of bed, plus your activity. So that's like you going for a run. And then the thermic effect of food. So the energy that you actually use to digest the food that you're eating. The hypothalamus is your long-term adiposity center. So that part of your CNS or your brain controls your appetite, your metabolism, and essentially your physical activity, because it'll make you like, shake your leg and annoy everyone around you and everything like that. And you have appetite promoters and suppressors, which I might talk a bit more in nutrition. It might also be good to note that there is weight homeostasis, so your body tries to maintain a weight set point, and it's controlled by negative feedback. And so if you lose weight, your metabolism will adapt for you to essentially get more nutrients from your food so you don't lose too much. Etiology and risk factors. It's important to note that it's genetics is present in up to 70%. So it's not all the patient's fault, but it is related to obviously a sedentary lifestyle, which is someone who sits all day, doesn't really exercise, poor dietary habits, high in fats, sugar, or overeating, mental illness like binge eating disorder, night eating syndrome, hormonal hypothyroidism being the big one like before, medications, corticosteroids, you will have to know eventually, and the pill is controversial. Age, so when you're older, postmenopause, prior pregnancy, quitting smoking because smoking decreases your appetite, and low SES. It's associated with basically everything, and if you can look through these and be like, yeah, I know that, that would be good. In terms of treatment, so the major one is lifestyle. So you'd set goals, set a SMART goal, modify their diet. So it doesn't really matter what diet they go on, but adherence is the most important predictor of success, and recommend diets with at least 800 calories for a long-term approach, and try to get them to exercise more than 30 minutes, 5 to 7 days a week. In terms of pharmacologics, candidates are must have been quite serious. Basically, you don't give this to everyone, and I wouldn't say you have to know these very well. And bariatric surgery, again, has to be even more serious. So BMI over 40 or BMI over 35 with a comorbidity. And this is when they've tried everything else. So you might get like a gastric band or a lap band and see how it constricts right there to stop food going in very quickly, essentially. And that makes people eat slower and eat less. And a gastric bypass basically gives you a tube going from your esophagus all the way to your intestines. Peritonitis could be a cause of your acute abdomen, and it's an inflammation of your peritoneum, so that covering that encases everything in your abdomen. And it's very, very, very severe. So patients will come, I don't even know if they'll come, they'll call the ambulance, and you'll see them lying really still on the floor with like their arms basically fully outstretched, and they're not going to move at all. And that's because they're in so much pain. You'll get abdominal rigidity, but I wouldn't recommend kind of palpating them too much. And basically the major sign on examination is rebound tenderness. And that's when you kind of push in like this, release really quickly, and you get them screaming in pain. And because they're in so much pain, they're in shock, they've got nausea, vomiting, they've got fever, and things like that. And it's very serious. So send them to hospital, give them antibiotics, give them fluids, and then check what's caused it, which is often like a perforation or something like that. An abdominal aortic aneurysm, or a AAA, is when the aortic diameter here is more than 3 centimeters. So the typical patient for this is like an old male smoker with a family history of like cardiovascular disease. And it's not serious until it's ruptured. And so basically if you discover it early and it's small, you keep an eye on it. But if you discover it and it's big, then you would consider surgery. Or if it ruptures, obviously that's immediately send them to theatre. So they're usually asymptomatic unless it's expanding rapidly and then it'll give you like abdominal and back and flank pain. And this back pain, remember, because it's retroperitoneal, and so it's going to radiate all the way to the back. And then on palpation, which you do in your abdominal exam, you want to press down really quite heavily like this down the middle of their abdomen, and you can kind of measure how big that expansile pulsatile mass is, and that's a buzzword. So yeah, rupture will lead to retroperitoneal hemorrhage. Hemorrhage is just bleeding, and that's what gives you the shock and the pain radiating to the back. And you can diagnose that with an ultrasound or a CT. Portal hypertension. So remember our portal system here, basically draining things from our GI tract straight to the liver first, where everything is kind of moderated before sending it back to our systemic circulation. So there can be, the causes can be kind of sorted into 3 areas again. So prehepatic, intrahepatic, and posthepatic. So prehepatic will be portal vein thrombosis. Essentially, if you block something here, then obviously the pressure is going to backflow to everything, causing portal hypertension. Intrahepatic cirrhosis. So that's basically if the liver is cirrhotic, then the vessels in there are pretty cramped and pretty squished. And so that brings back pressure again. And then posthepatic is like Buchiari syndrome, which you don't have to know very well. It's congenital syndrome, which causes portal hypertension. And the main things you want to know, I would say, about portal hypertension are its complications. So you get esophageal varices leading to hematemesis, or a Mallory-Weiss tear, which is a vertical tear of your esophagus. It'll go like that. And the classical presentation of that is people are vomiting a lot, and then suddenly they're vomiting blood because of the tear. And this is because of the places of portal systemic anastomoses. So at the lower esophagus, you get a joining of the portal system, which is the left gastric vein over here, and the esophageal vein in the systemic circulation. And likewise, in the upper anal canal between the superior rectal and the inferior middle rectal, you get another anastomosis, and that causes hemorrhoids, so bleeding out your butt. And then by your umbilicus, you can get caput medusae, basically. So this is very serious. Usually you won't get this. Usually you get like a little bump, like something like that big, if you're lucky. And then you also get ascites. So that's like big bloating of the belly, and that's what you test shifting dullness for. So portal hypertension is usually asymptomatic until things like this develop, but it can also cause things like splenomegaly, and because it's causing, it might be due to liver issues. You might see some things like encephalopathy, which is like confusion, brain issues because of liver failure, jaundice, things like that. And you would treat that with beta blockers and nitrates. I wouldn't say that learning the management for all of these things is very important at your level. Abdominal hernias. This is high yield. So hernias are basically when something outpouches where it's supposed to be. And they can happen in a lot of sites in the abdomen. So if you look at some of them, the esophageal hiatus, I'll go over here for hiatus hernia, but you can see here, you can get your inguinal ones here and here. You can have one at the umbilicus. You can have one at epigastric region, which is less common. Incisional at sites where you've previously had surgery, or femoral over here in the femoral canal. And often these can be direct or indirect. Direct are through areas of weakness, and so there should be a wall there, but it's not there. Whereas indirect is if there's already a channel and it just happens to slip through the channel. So your lumbar triangle, which comes up very, very infrequently, is actually at your back. And you can search a picture of that later. It's not very high yield. In terms of complications, it can be incarcerated or obstructed. So you can think basically if you have a loop of intestine and it's popped out kind of your anterior abdominal wall. And then it starts getting stuck together to the abdominal wall via adhesions and things like that, or it might do a little bit of a twist, or because the opening is small itself, it might be obstructing. So when you obstruct basically the food or the poo that's trying to go through, then you get like bowel obstruction symptoms like bloating, like nausea, vomiting, things like that. If you get places that are obstructed in two areas, that can be very, very bad. For strangulated hernias, that's when you actually cut off the blood supply, and that's when the bowel actually starts to die, starts to necrose, and that's very, very serious. So both of these, I would say you're taking them to surgery usually. And then if it becomes strangulated or obstructed enough, it might actually just rupture. And because it's leaking the contents of your bowel into your peritoneum, you get peritonitis. And then that again is super serious. So how do you diagnose this? Usually it's pretty benign. Usually it's just reducible. You can push it back. So they might come in to the GP and you put your hand on it, basically ask them to cough. And because a cough increases your intra-abdominal pressure, that'll make the hernia kind of bulge out against your hand. And that would be a positive cough reflex. And then you try to push back in. So treatment is usually, watchful waiting, push it back in, or if it's serious, give them laparoscopic surgery. And this here is Hasselbalch's triangle, which is an important area of weakness for direct inguinal hernias. Okay, great. I've still got it here. So I'll go through some of the important ones. Inguinal hernias, more common in males, can be direct or indirect. So indirect is more common. Indirect, like I mentioned before, is not directly through any wall. So it's passing through your inguinal canal, through the deep inguinal ring. So if these are your inferior epigastric vessels, then your deep inguinal ring, which they've illustrated here for this one, is where it would enter, and then it'll go all the way through your inguinal canal out, and often it might enter the testes or the scrotum. For direct, these are through Hasselbalch's triangle. So Hasselbalch's triangle, like I mentioned before, is like a pretty thin piece of your anterior abdomen, and it's between your inferior epigastric vessels, your rectus abdominis, the lateral border, and your inguinal ligament. So I think the borders are quite important to know for anatomy. So these are medial to your inferior epigastric vessels, and that's when the hernia pops right out of the wall. So it just kind of pops through. And this can exit through the superficial inguinal ring, but it usually doesn't enter the scrotum because it's pretty direct there. Femoral hernias over here will happen through the femoral canal, which is underneath the inguinal ligament. And the main thing to know is that they're really susceptible to bowel strangulation because the neck of the femoral canal is really narrow as opposed to these two, which tend to be a little bit bigger. Incisional hernias, like I mentioned before, is usually due to surgery. And then diaphragmatic hernias, mainly esophageal ones, but they can also be aortic and caval ones. And they may occur along embryological areas of weakness, but I wouldn't say that's important to know at all. You probably learn in fourth year. So these are your hiatus hernias, and that's your stomach. That is your diaphragm. Like that. They can be sliding most of the time, 90% of the time, which is when basically your cardia, so remember, I don't have a good picture of a stomach here, but your cardia is kind of like this bit, whereas your fundus is like the bit that comes out the top like that. So the cardia goes through, it slides through like its name, and usually they're pretty asymptomatic or minor, but it can cause some chest pain because it's irritating the things around it, as well as reflux, as you can imagine, because your lower esophageal sphincter, as a functional sphincter, relies on that angle, and you don't have that angle anymore. A paraesophageal or a rolling hiatal hernia is when the fundus goes through, and these are associated with more severe complications because it can strangulate. And then diagnosis is usually via a chest x-ray. You might give them a barium swallow like before, and then treat basically the complications. Or if it's very serious, then you might do this operation called a Nissen fundoplication, where you bring the fundus around and attach it again, and you can see that kind of like gives it something more substantial to push against that hole. Pathology of the alimentary tract. So this is GORD. We've touched on this quite a lot already, but essentially, as mentioned, it's failure of the lower esophageal sphincter, usually due to conditions that force abdominal contents superiorly, like pregnancy, obesity, things like that, or excessive drinking and eating, which basically your stomach gets too full, starts going back up. And the main symptom is burning epigastric pain or heartburn, but you might also get things like acid rash, which is when acid comes back up to the mouth, so you get like a bitter or a sour taste in your mouth. And you treat that with antacids, H2 receptor antagonists, PPIs, and it can occur in babies. I don't think it's that important to go through that though. Peptic ulcer disease is related, and that's when you get these ulcers in the lining of your stomach, and they can be gastric or they can be duodenal. Gastric ulcers are more common in older people, and again, this is your dyspepsia or your heartburn. For a stomach ulcer, you usually get more empty stomach pain because when you have food, it kind of neutralizes the acid. Or if it's pyloric or duodenal, then you usually get pain with food, and that's because, a little bit after food, because it passes through your stomach and then it starts irritating, like brushing against the ulcer there. You might also get symptoms such as like bloating. You might get like people might burp a lot, they might get flatulence, things like that with peptic ulcer disease. And the complications, obviously it bleeds, so it can cause anemia, chronic anemia, which is normocytic, and perforation. So this is like high yield stuff. If it's gastric, as you can see here, you can have it affecting your left gastric artery, which is a bit less buzzwordy, but it can if it happens along the lesser curvature here, or it can hit the splenic artery right behind it, or it can actually hit the pancreas. For pyloric ulcers or your duodenal ulcers, then it can hit the gastroduodenal artery right here. So how does this happen? Usually it is always a disruption and balance between your defense forces and the aggressive forces. So the aggressive forces being your acid, your pepsin, your pepsinogen, as well as H. pylori is a big one. So H. pylori causes 80% of gastric ulcers and 95 to 100% of duodenal ulcers. So that's your major risk factor. But other than that, you can get your NSAIDs. As Gavin touched on before, that's because it stops your prostaglandins from working as well and giving you like those protective mucosal measures. Corticosteroids is also quite a big one, actually, as well as smoking and alcohol. You can diagnose it pretty well with a breath test because how much H. pylori is related to it. But you can also test for H. pylori in like blood, in stool, so there are quite a few ways, and then you treat them through kind of 3 steps pharmacologically. So anti-secretory agents is aiming to decrease your acid production. So these are like your PPIs, your anticholinergics, your H2 receptor antagonists, and then you can increase your defense. So cytoprotective agents and mucosal strengtheners, your antacids, your colloidal bismuth, your sucralfate, and your misoprostol. And then number 3, you want to eradicate your H. pylori by a triple or quadruple therapy. Just H. pylori really quick again. So gram-negative rod, these are the main virulence factors. So urease, breaking down urea to form ammonia and hence neutralize the acid around it and protect it itself. The flagella here to allow it to move around in the stomach. Lipopolysaccharides to allow it to adhere. And then exotoxins to actually break the stomach epithelium to form the ulcer. And these VAC-A and CAG-A exotoxins can also actually cause gastric cancers, which are a big complication. And that's why you actually want to get rid of the H. pylori even if you only have mild disease, because you don't want to put your patients at risk of cancer. Again, diagnosis by urea breath test, and then your combination therapy, so your CoA, clarithromycin, esomeprazole, and amoxicillin. And lifestyle, avoid spicy and oily foods, and smoking cessation. Gastric carcinoma is a malignant cancer, usually caused by things like chronic gastritis. So when your cells are always inflamed and then trying to heal themselves, it's proliferating more, which predisposes it to cancer, because more errors can occur while you're trying to essentially replicate your DNA. Pernicious anemia and polyps can also predispose you to gastric carcinoma. And usually patients get like this vague pain. They might get full a little bit easier. They get anemia because it often causes bleeding, and it might cause obstruction as well. So usually you just do imaging things to find this. Bowel obstruction. So this is like a big imaging thing. But patients come in and it's usually like colicky pain. Like I mentioned before, anything obstructed will give you colicky. So starts and stops and starts and stops because it blocks and then it kind of can go through, and then it blocks and kind of can go through. So you get colicky pain. I said central, but really can be anywhere, and it really depends on where it is. And because it's blocked it, you're going to get air in it, and it's going to get really distended, and so you'll see abdominal distension, and eventually it'll cause vomiting, constipation. They won't pass any wind because it's all blocked, and that's your typical patient. So usually, it can be mechanical or functional. So mechanical would be an actual blockage. So something like a mass, a tumor, or even like a stricture. So things like IBD can cause strictures, like actual restrictions of your bowel. Or it can be functional. So after surgery often, especially for older patients, their intestines will just like fail, and it just won't move. And usually you just treat them conservatively, and it's all good. And it'll come back later. But yeah, bowel obstruction is usually post-surgery. So after surgery, your bowel, essentially your intestine, it's very messy, and so it develops all these things called adhesions, and that can cause obstruction. But also, like I mentioned before, hernias, tumors, and volvulus, which we'll cover next. The complications are dehydration and electrolyte abnormalities, because as you can imagine, food and water, not only are they like vomiting, but it can't reach all the areas of your intestines properly. And then when it gets dilated enough, it can actually perforate, or it can, and then you get peritonitis, and you get like shock, and it's bad. So diagnosis, you do an abdominal x-ray, so AXR, and you can see these dilated bowel loops. So this one on the left, they're lying supine. And you know that because when they're erect, you get an air fluid level like that. And you know this is small bowel because they have these plicae circularis going all the way across like that. And it's kind of central. Whereas large bowel will usually sit kind of like this, where it is anatomically, and it'll be a lot bigger. So in terms of these patients, you would treat them with fluids, be supportive, and then relieve the obstruction via surgery. This is a volvulus. So a volvulus is when, as you can see here, the bowel actually twists on itself. And because of that, it obstructs itself. It usually happens in the sigmoid colon or the cecum. And this one, you know, is a sigmoid one because remember, your large intestine starts here in the right side, goes up, across, down to your left, and then it goes to your rectum here. So your sigmoid colon is sitting along here, and you can see that this kind of big loop here starts and ends on the left side. So you know that's a sigmoid volvulus. And the big sign, they call this like a coffee bean sign. If it starts on the right side, then it's usually a cecal one, because your cecum is here. Again, you kind of get the same symptoms as your bowel obstruction, and then this is what you see on X-ray. And usually you can do surgery for this, or you can do like a sigmoidoscopy, which is like a colonoscopy. It's another tube with a camera on the end. You basically stick it up their butt, and once it reaches here, it kind of just untangles itself, and you get like air and poo all over everyone in the room, and then they're fixed. Hirschsprung's disease is a congenital disorder of the colon. So you usually have these ganglion cells in your myenteric and submucosal plexus, and they're not born with that. And because of that, they don't get any signals back up to the brain, and that causes chronic constipation. And as you can see here, no ganglion cells. The bowel itself is kind of atrophied, and then because it's atrophied, food can't get through, and they get this huge obstruction, becomes very bad and necrosed. So this is like a baby who's constipated, vomiting, having diarrhea, abdominal pain, and then what you do is you go in, get a biopsy, so get a little sample, and then they'll tell you if that's what's happening. Celiac disease is another high yield one, I think, for second year. And this is a systemic autoimmune disease. So autoimmune means that it's your body attacking itself. And it's triggered by gluten, and usually affects the duodenum, but it can affect anywhere. It's in 1% of the population, so it's pretty common. And it's associated with a lot of other autoimmune diseases. So think diabetes, thyroid disease, lactose intolerance, infertility, etc. And because it's associated with all these things, it's also quite genetic, and usually in Europeans. The symptoms are pretty diverse. Most of it's due to malabsorption and caused by structural differences. So they get chronic diarrhea if they're continuing to eat gluten, of course, steatorrhea, bloating, distension, anorexia, failure to thrive, lethargy, weakness. So it's actually very severe. This is not your like typical, oh, I don't like gluten, I'm not going to eat it. They get a lot of symptoms. A lot of them, when they eat gluten, they can't work. They're super bloated. They can't put their pants on. And so it's quite severe. And because it affects the duodenum, it affects a lot of absorption of your nutrients. So for iron, because you're not getting enough iron, you get iron deficiency anemia. And because of that, you get your weakness, you get your lethargy, you get your fatigue. In terms of calcium and vitamin D, you get osteoporosis, so they're getting brittle bones. B12 and iron deficiency will give them angular stomatitis, which is when you kind of have this red raw area around your lips, as well as dental enamel hyperplasia, so lots big gums. You also see dermatitis herpetiformis. So these are these little lesions, usually over the extensor surfaces of arms and legs, and it's also related to infertility. So the treatment is actually a strict lifelong gluten-free diet. We don't have any drugs for it. There's nothing that we can give to them. So how does this happen? Essentially, it's a loss of immune tolerance to antigens from gluten. And you don't have to know this entirely perfectly well, but some things help you to understand how we diagnose it. So in the stomach, gluten is converted to gliadin, and gliadin should be absorbed through your enterocytes, but essentially is bound to TFR, which is transferrin receptor, and moves into the lamina propria, which is in the mucosa of your gut. And that's where TTG, or tissue transglutaminase, deaminases gliadin. So you can see here for the celiac serology, we have TTG here. So we're looking for the antibody against this. And then because it deaminases gliadin, we're also looking for deaminated gliadin peptide in the celiac serology. And then that essentially is presented on macrophages. It activates your T cells, and it goes through all the usual Th1, Th2 pathways, and attacks itself, essentially. And that's where you get your pathological changes. And this is important. This is kind of the triad you have to know, because this is the proper way you would diagnose celiacs. So the proper way you would diagnose celiacs is you take a duodenal biopsy, and they do that through a tube, called an endoscopy. So instead of colonoscopy of your butt, endoscopy through your mouth. They send the tube down with the camera, and then there are these little ports where you can have like these little pincers. They pinch a little bit and they bring it out, and it's a tiny little bit, but it's enough. And then you send it to the path lab, and they see this. So they see atrophy of the villi over here. So you can see the villi tall, they're huge, this is healthy tissue. And then on this side, it's just kind of big, because all the villi have atrophied. You get hypertrophy of intestinal crypts. And so over here, you kind of have these little tiny crypts in healthy tissue. Over here, you have like massive ones. And then you get a lot of lymphocytes. So lymphocytes show up purple on biopsy. And so over here, you don't really see that much. Whereas over here, this is literally filled with purple lymphocyte infiltration. So this is your gold standard. You kind of have to do this and diagnose it, because the celiac serology is not fantastic, and gene testing is very bad. And both of these you would have to do on a gluten diet. And as I mentioned before, it can be quite like severe, right? So lots of patients don't actually want to, they've discovered they can't eat gluten. They don't want to go back on a gluten diet to do all this testing. Irritable bowel syndrome is a chronic condition, and it's kind of like, it's tummy issues with no apparent reason. So people get constipation or diarrhea, they get abdominal pain, they get bloating, but their examination is normal, and it's usually relieved by like defecation. It affects 15% of the adult population, so it's actually quite a lot. And they have no idea what causes it. It's probably multifactorial. And so you diagnose it based on history, determine any dietary associations, and then treat it by targeting the causes or the symptoms. So you can put them on something called a low FODMAP diet, which is essentially an elimination diet. They can start eating only like a couple of foods, which they know are usually pretty safe, and then they start adding things back in one by one to see what they're sensitive to, and then treat the symptoms. So constipation, you can give them stool softeners, osmotic laxatives. For pain, you can give them antidiarrheals, and then manage their stress, anxiety, and depression. For inflammatory bowel disease, so this is more like severe. Not to say irritable syndrome isn't severe at all, but this is when your bowel is inflamed because it's inflammatory bowel disease. It's characterized by chronic diarrhea. So you usually have a patient who's young-ish, because it's pretty genetic, like 30s maybe. They've got chronic diarrhea, they're seeing blood in their stool, and they've got diffuse abdominal pain, so it can be anywhere. And the diagnosis is via colonoscopy and biopsy. You stick the camera up their butt, and you take a bit of the sides where you think it looks wrong, and then they've got like these pathological changes, which they'll tell you about in the path report. There are two types of IBD. So it can be Crohn's disease, or it can be ulcerative colitis, and they're actually quite separate. So Crohn's disease is a more diffuse inflammation. So it can happen anywhere in your gut, and they're characterized by these things called skip lesions, because it can be anywhere, but it kind of like has unhealthy and then healthy, and then unhealthy and healthy. And so not your whole gut is actually, well, it can affect your whole gut, but not everything's affected. Whereas ulcerative colitis starts from your anus up and it moves proximally, but it's colitis, right? So it only affects your colon. And that's why for ulcerative colitis, if you cut out the colon, then you've cured the disease. For Crohn's, you can't cut out the whole gut, so you can't do that.
Just to add on to that, like if you're having trouble remembering which one's which, the way I remember it is like Crohn sounds like crow. So like a crow is like hopping along. So it's like skipping. So skip lesions. Yeah.
That's a good one. Crohn's also is transmural, as opposed to like a more shallow, like a more shallow ulcer for ulcerative colitis, which is in the mucosa or submucosa. And what that basically means is for Crohn's disease, you can end up like having these big strictures and things like that because it's dug in and then it forms all this scar tissue. In terms of pathophys, you don't have to know too much. They usually have a family history and they don't know what causes it. And that's why you don't have to know it very much. Chronic diarrhea and bleeding, weight loss, possibly right up lower quadrant pain, but usually diffuse. And both Crohn's and ulcerative colitis, you can get symptoms outside of the bowel. So you might get like arthritis or painful joints, which you can't move very well. You might get eye issues. And that's a pretty big characteristic of IBD. You confirm it by biopsy, colonoscopy and biopsy, and then you'd monitor it a lot. You're trying to cause remission because it attacks and flares, and then give the medications like anti-inflammatories, immunosuppressants, and see if that helps. For ulcerative colitis, really similar, but yeah, basically just affects the colon. Relapses, toxic megacolon is a big risk. And that's when you get this huge dilation in your colon, which can be perforated and cause peritonitis and hence cause shock, and then it's bad again. Endoscopy and biopsy, or colonoscopy and biopsy, is how you would diagnose it. And then it's really similar to how you would treat Crohn's, except, of course, a colectomy would cure the disease. So whenever you see something like TOMI, like cholecystectomy, colectomy, that means you're taking something out. So this is just removal of the bowel. Colorectal or bowel cancer is another ICL for you guys, I think. So this is a little bit big. It's a malignant tumor of the colon or the rectum, usually the colon, in 2/3 of the time. And you would stage it via T&M staging. This is like the major staging system they use for most of the cancers. So it's really easy to remember because T stands for tumor. So that's how deep the primary tumor has grown into the bowel lining. N is lymph nodes, N for nodes. And so if it's spread to any nodes, that's when you start at N1. And then M is metastases. So that's the extent of distant metastases to other organs. This is it's the most common cancer in the Western world, or the third most common in Australia, and is the second largest cancer killer in Australia. And the biggest risk factor is basically age, but it's also more common in males. This is the pathology. Essentially, it arises from these like adenomatous polyps. So you got all these like little bumps in your colon, and they get bigger and bigger until they get dysplastic. So they're starting to change cell type a little bit, and then you get a huge pedunculated adenocarcinoma over here, which looks like a mushroom. And that's when it starts getting malignant. Here, this is actually quite important. So familial adenomatous polyposis, caused by the APC gene, I think, is a tumor suppressor gene. And that causes a heap of these polyps to build up in the colon. And this is obviously a congenital disorder, and these people have to get these polyps removed quite frequently, pretty much yearly or every couple of years. Otherwise they risk, they have a huge risk of bowel cancer because they just have so many of these, and they could all potentially develop into cancer. Screening is done in Australia every 1 to 2 years for everyone above the age of 50. This FIT, or fecal immunochemical test, is sent to everyone above the age of 50. And it's really important to note that a positive does not mean they have cancer. A positive means that there's blood in the stool, which is something that the cancer may cause, but it also could be anything else that causes blood in the stool. So once they test positive to this, then they might go in and actually get diagnosed with a colonoscopy. And if they see anything strange on the colonoscopy or the camera, they might take a little biopsy, then send it to the labs, and then they'll tell you if it's cancer. If you have a genetic background, then you get your colonoscopy every couple of years, and they might be on low-dose aspirin. So how does it present? Usually it's very people don't notice it. They might get the normal cancer symptoms called the B symptoms: weight loss, fever, night sweats. They might get rectal bleeding, causing anemia. They can have a change in bowel habit, so they might be getting constipation, diarrhea. Like I mentioned before, likely due to obstruction, because it obstructs and then it lets it go. So when it's obstructing, you're getting constipation, and then when it finally builds up enough that it pushes through the obstruction, you get diarrhea. You might get urgency, tenesmus, which is basically urgency. You might feel a mass on palpation, or you might get abdo pain or swelling, depending on what it's impinging on, depending on whether it's obstructing something or not. So if you start at the right-sided colon, these tend to have the darkest stools, and that's literally just because if it's bleeding, it picks up blood and then it digests a little bit more before it comes out. And these are hard to pick up because they're so early on. And then it might move to the left-sided colon. Well, it won't move. If it's on the left-sided colon, these are a bit more obvious. This is when you tend to get your overflow diarrhea. So your constipation diarrhea, where it's blocking and then letting it go when it overflows. You tend to get more obstructive symptoms, so bloating, nausea, vomiting. And then down in the rectum, if it happens there, if you have a mass in your rectum where, like Alina said, you can actually sense it and it makes you want to pass stool, you can get urgency or tenesmus. And that's when the bleeding is bright rather than dark, because it's right there and it comes straight out. Complications, it might metastasize to the liver, the lungs, the peritoneum, and then chemotherapy has a whole range of issues on its own. Diagnosis, like I mentioned before, endoscopy and biopsy, and then treat it via a couple ways. Essentially, the idea of cancer is you can cut it out, and then you do radio and chemo to try to get rid of any remnants. So a polypectomy, like I mentioned before, tomy means they're taking something out. So polypectomy, they're taking out the polyp, which is this or these. Colectomy, they're taking on the colon. Stomy means they're going to basically take a bit of the gut out to the anterior abdominal wall, and it's literally it's left out, they make another butthole in your abdomen, and then they fix a stoma bag on there and it catches it. So colostomy is when they take off a part of the takeout, basically they unjoin the colon and then they take the end to your anterior abdominal wall and it feeds out for a pouch. And ileostomy is when they take it from the ileum up to the your anterior abdominal wall. And usually these are temporary. So if they take off a bit of your colon, for example, they don't want to just fix it up and then let you keep eating things, and your bowel hasn't even properly healed yet. You might get an infection, you might get peritonitis. So they do the stoma bag, they bring it to the front temporarily, and then allows your body to rest, and then they might rejoin it later. So prognosis is pretty good. So 98% can be treated successfully if found early, and that's why you have the screening. But the 5-year survival rate is low because so little people find it. Appendicitis. So this is another cause of acute abdomen. People come in, they're like, oh, I had this pain that was by my belly button, and then it's moved now to my right iliac fossa, and it's gotten a lot worse. And now I'm vomiting, and I'm really nauseous, and having fevers because I'm so like in shock. So that's appendicitis. That's like pretty obvious. Some of the main points which they like you to know is 1, McBurney's point. So when you're palpating, this is 2/3 the distance from your umbilicus to your aces. So that's right there. And that's where they'll feel the pain most. So when you press down on that, it really hurts. Rovsing sign is when you press on the left side, the left iliac fossa, and they feel pain on the right side. And that's because the pain refers through the peritoneum. You might get rebound tenderness, which is just a normal sign of peritonitis. And this is causing peritonitis. And you can also test the obturator and psoas signs. The obturator sign is when you're flexing their hip and their knee, so like this, and then you internally rotate. And you can imagine that kind of impinges on the appendix in their right lower quadrant, and that will cause pain. The psoas sign is when they have their legs straight and you just passively flex their hip. And that basically, if the appendix is behind your cecum or retrocecal, it can hit your psoas muscle, which is like on your posterior abdominal wall. It'll cause pain, essentially. And the treatment, initially when they're coming in, you just support them. You give them pain relief, you give them fluids, and then you send them to surgery. They get their appendix taken out, and it's all good. Diverticular disease might also be a presentation of acute abdomen. But it also might be just something people have. Essentially, there are these little pockets like this, and it's usually just because you get so much pressure in here that kind of your bowel wall starts herniating a little bit. You get all these diverticular. And so when that's present, you have diverticular disease. Usually it's through your sigmoid colon, which is, again, in your left lower quadrant, and it's caused by poor fiber intake and obesity. So if these get infected, which it can happen very commonly, kind of similar to appendicitis, like because they're little pouches, it's pretty like there's a lot of stasis, things don't really move along, and because it's not moving along, bacteria can build up. And then you get inflammation, and they call that diverticulitis, itis for inflammation. When that happens, they get really severe abdominal pain, they get fever, and then they come into the emergency department with acute abdomen in their lower left quadrant. This is basically one of your only differentials for lower left quadrant pain, perforation or diverticulitis. So if it perforates, obviously you get peritonitis, which is bad. You can get abscesses, which are like collections of inflammatory cells and bacteria. Or you can actually get fistulas. So fistulas is like a connection where there shouldn't be. So if you get a fistula between here and, for example, your vagina, that would be bad, because then like fecal matter starts coming out of your vagina. Treatment is antibiotics if they have diverticulitis, and surgical resection if it's really bad. But otherwise, it can be managed pretty conservatively. And you can usually see this on imaging. It literally looks like little pouches. Alrighty, any questions so far?
Just as a quick thing to add on to all of that, a lot of the detail is like, will come in like next year as well, so in third year. So just like don't stress out too much about a lot of that, all the detail. Make sure you know like the really fundamental conditions, like appendicitis, that's like really fundamental, and all like the bolder stuff is really important. But in terms of like the specific path, sometimes just like don't stress too much. If you know all of it, just giving it to you because you feel like keen and you want to learn it all. But a lot of the time it'll be quite obvious for you guys as well. This is just
Yeah, absolutely.
like the broad.
I think in second year, a lot of it is learning it in context with your anatomy, with your pharmacology, things like that, with your physiology. But yeah, it's also good to know because you get into third year and then they ask you in the hospital and you're like, wow, I learned that in that one PSPanda Zoom call. Alrighty. If we don't have any questions, I'll move on. Pathology of accessory organs. So this is an annular pancreas, which is a congenital abnormality. I think they mentioned this really briefly in embryology, but essentially it's a vomiting baby who's not really thriving, and that's because you've got this bifid ventral pancreatic bud, and it wraps around your duodenum, and it basically strangles it. Diagnose it by an ultrasound. Pancreatic cancer, you only really need to know a little bit about it. It's usually in the head and neck of the pancreas. So remember, your pancreas is kind of this shape. It's like here or here. And it's called a silent killer because nothing happens and then they die. Often, or not often, very occasionally, a cancer in the head of the pancreas can obstruct the bile duct and cause obstructive jaundice, but otherwise they don't really get many symptoms, and that's why it's so dangerous. Acute pancreatitis, I think, is a big one in second year. It's an ICL. So it's pancreatitis, right? So inflammation of the pancreas. And usually that's due to autodigestion because remember our pancreas is what releases all these amylases, lipases, and proteases via the ampulla of Vater and the major duodenal papilla into the duodenum and allows us to digest all the things coming in from the stomach. They don't know exactly how it works, so I wouldn't be too stressed about the pathophysiology, but I think they did mention in an exam question zymogen granules. So these are your proenzymes, and they turn into proteolytic enzymes, such as trypsinogen, and that ends up digesting the pancreas itself, leading to destruction, leading to things like pseudocysts and pancreatic insufficiency. Etiology, there's a mnemonic, get smashed, but in my opinion, I don't even know all of these yet. So there's no point learning them. These two big ones, they want you to know though. So the first one is gallstones. How does gallstones cause pancreatitis? It blocks this duct here by the ampulla of Vater because it moves all the way down from the gallbladder down to choledocholitis, which I'll cover a bit later. But then because it blocks right there where it's met the pancreatic duct, then it can actually, when the pancreas try to secrete things, it can backflow. And it's secreting all the digestive enzymes. So it backflows and it ends up digesting the pancreas itself. And then another major cause is ethanol or alcohol. And that's, again, this is like a major amount to know, but just know that it's related to more zymogen secretion and activation. How do you diagnose this? Well, remember your pancreas is secreting your amylases and your lipases. So you're testing for these in the blood because it's not able usually to enter the duodenum, or it's just like leaking. And so it'll all enter your blood. Lipase is better than amylase, and so increases in those will indicate acute pancreatitis. And then on CT, which is imaging, you might see inflammation, you might see necrosis, and you might see a pseudocyst like this. So these guys present with really, really, really bad central abdominal pain. So it's acute abdomen, again, radiates the back, severe and constant, and it's not relieved when sitting up. You might see Cullen's and Gray-Turner sign on your abdo exam. So Cullen's is umbilicus and Gray-Turner's is flanks. And they're both bruising. So I think Gray-Turner's because Gray means bruising and Turner's is on the flanks. And then Cullen's just constant. Nausea and vomiting because it's causing them so much pain.
Another way you might choose to remember it is like Cullen starts with a C. So like sometimes you see a C. It actually makes a C shape around the umbilicus as well.
Yeah, that's a good point. In terms of management, manage the pain, IV fluids, treat the complications, give them antibiotics. And then if it's really bad, if they have like a cyst or something, then you have to go into surgery and actually get that stuff out. Chronic pancreatitis, again, is just massive on the alcohol. So like a typical patient that comes in with pancreatitis will be like someone, if it's an anoscopy, for example, be like, ow, I'm in so much pain, I don't want to move, I'm nauseous, I'm vomiting, and I drink a lot. Or, oh yeah, I had gallstones. So that'll be your pancreatitis patient. Chronic pancreatitis gives you more of these like chronic symptoms, like continuous abdo pain, weight loss because of malnutrition, because you're not digesting things, because your pancreas isn't working well. Diarrhoea, again, because it's got your lipases, you're not digesting your fats, and so you get these loose, floating, pale, smelly stools. And treatment is usually pancreatic supplements. Don't let them drink, and give some pain relief. These are the colis. So I think this confuses a lot of people, but it's actually, if you think about it enough, if you sit down and just think about it enough, it's quite intuitive. So if you split them up, there's actually 4, right? 2 things from the gallbladder, 2 things from the common bile duct, 2 things that have stones, and 2 things that are just inflammatory. So the stones all end in lithiasis. And because it's a stone, whether it's in the cystic duct or the common bile duct, it's because it's obstructing, like I mentioned before, it's going to give you that colicky pain. So that intermittent coming and going, whenever it blocks the duct, it gives you some pain, but then it might fall a little bit, or it might go back a little bit, and then it stops giving you pain. So it's colicky. And with colicky pain, patients are often writhing around. They're not moving. It's not like peritonitis where they're completely still. You want to diagnose stones with some kind of imaging. So like ultrasound is gold standard, or you might do an ERCP where they stick a tube down here, and then they can actually look up here. So cholelithiasis is gallstones, so in your gallbladder here. And there you get your colicky pain, but usually it's asymptomatic. Why? Because it's your gallbladder. It's not blocking your cystic duct yet. It's chill. Choledocholithiasis is when it's in the duct. So I think both are lithiasis, the one with the D for duct, choledocholithiasis. Stones in the bile duct. And because it's blocking the bile duct, you get obstructive jaundice because your liver, the bilirubin, is not able to pass through. And so it's going back and going into your blood and things like that. And so you get your pale stools, you get your dark urine, you get your jaundice, and you get your colicky pain from the stones itself. The other 2 are the inflammatory ones. So you have your cholecystitis and your cholangitis. How do I remember this? Cholecystitis, lots of things related to the gallbladder have cyst in it, like the cystic duct, or the cystic artery, which is usually there. So cholecystitis is your gallbladder inflammation. And this is characterized by your Murphy sign. So that's the sign where, I'll talk about this more during the examination, but you kind of press down on their right underneath their right rib cage, and when they breathe in, they'll catch their breath. And that's because your hands, when breathing in, your diaphragm moves down, it moves the gallbladder down, and then it hits your hand, which is right under your rib cage, and that gives them pain because it's inflamed. Cholangitis is when the bile duct itself is inflamed. And when the bile duct is inflamed, it gives you Raynaud's pentad or Charcot's triad. So Charcot's triad is jaundice, fever, and pain. And Raynaud's pentad is basically Charcot's triad plus shock and altered mental status. So this can be quite bad. In inflammation, you tend to get prolonged sharper pain as opposed to colicky pain. And you also have an elevated CRP, because CRP and ESR, these are 2 blood tests that tell you that something is inflamed in the body. All the pain is in the right upper quadrant. And bile duct issues, so choledocholithiasis and cholangitis, will give you elevated ALPs, GGTs, and conjugated bilirubin. So essentially, if you can know this slide, you kind of know the difference between all of these. If it's stones, you get colicky pain. If it's inflamed, you get raised CRP, you get sharper pain, and then, yeah, basically that's it. Go in a bit more detail now. So, one thing to mention is also, you should recognize that these can cause each other. So if you have cholelithiasis, if it keeps moving down, you get choledocholithiasis. If you get cholelithiasis also, you can, if it blocks there, then you can get cholecystitis because it's caused your backflow, and so your gallbladder is now inflamed. And likewise, choledocholithiasis can cause cholangitis. So often they're not alone, and that's why the symptoms can be so confusing. Cholelithiasis. So remember, these are gallstones. The main risk factors to know are the 5 Fs. So fair, fat, female, fertile, 40. I like to remember fertile also is related to estrogen, and that's why it's related to exogenous estrogen. Apparently not the pill though. And diabetes is also a big risk factor. It's usually asymptomatic because it's just sitting in your gallbladder. It's really happy. It doesn't really cause anything, and it's chill. Otherwise, if it enters the cystic duct, you get your biliary colic pain. So this is your right upper quadrant pain. It's coming and going because it's colicky. It may refer up to the shoulder because it might irritate the diaphragm. And the diaphragm is innervated by the phrenic nerve. C345 keeps the diaphragm alive. So that goes all the way up to your shoulder tip. You might get pain there. It is often after fatty meals because of your gallbladder squeezing against the stones, trying to get out your bile into your duodenum. And you'd usually diagnose it with an ultrasound or an ERCP. You don't treat it if it's asymptomatic because it doesn't cause anything. But if it is symptomatic, you just cut it out because you don't need it. And in terms of cutting it out, you can get post-cholecystectomy syndrome. So again, TIMI, cholecystectomy. Cyst is like your gallbladder, so gallbladder's coming out. And so they might get weeks of bloating, arbitrary abdominal pain, pale stools, but then your body adjusts and it's fine. They can be 3 types of stones. 90% are cholesterol stones. So radiolucent means that you don't see it on imaging. And then it can be these ones like bile stones and stuff like that, which isn't that important. Complications, also not hugely important. It can cause pancreatitis if it blocks the common bile duct. Merizi syndrome is really rare, and that's when it compresses the common bile duct, causing obstruction, even though it's in the cystic duct. So it's here, but so big it's blocking this. And then you might get fistulas. Choledocholithiasis, so lithiasis stone, D for duct, bile ducts, gallstones. So backflow can cause essentially obstructive jaundice, and that's why you get your yellowness of the skin, pale stools, dark urine, itchy skin. You get right upper quadrant or epigastric colicky pain because you've got stones, and you might get a fever. Complications, cholangitis, as mentioned before, and an ERCP, or endoscopic retrograde cholangiopancreatography, is both diagnostic and therapeutic. And that's the one where you stick the camera through all the way down here from your stomach to your duodenum, and then you can look up here. And basically they can grab the stones from here, and that's why it can also be therapeutic. Your LFTs, you'll have deranged GGT, ALP, and conjugated bilirubin. So again, that's your typical ductal issue. Cholecystitis, inflammation of the gallbladder, is usually due to gallstones. So 90%, it can be without a gallstone in 10%, but that's not important. You have a longer, more prolonged, sharper pain. You might feel a mass. They'll usually have a fever because titus means inflammation. Inflammation, you get fever, and it may just reserve. Murphy sign is the big one, and LFTs tend to be normal. You get an elevated CRP because they're inflamed. And again, you can take the gallbladder out. Otherwise, it's just wait, if it doesn't come back, it doesn't come back. Cholangitis, inflammation of the bile duct, is an emergency, usually ascending, which means it's like an inflammation or infection from your duodenum going up the duct rather than from your liver going down. And as mentioned, Raynaud's pentad. You'd usually do an emergency ERCP to decompress it, and then like fluid resus, strong antibiotics, supportive therapy, and like before with the choledocholithiasis, you get a deranged CGT-LP and conjugated bilirubin, which are your ductal ones. Alrighty. Cystic fibrosis, usually a RESP issue, also gives you like GI issues. The main thing to know is because it's a CFTRG malfunction, it causes like all your secretions to be weird, thick, annoying, excessive, and because of that, the pancreatic ones are excessive too, and excessively thick. And so you don't get proper digestion, and that happens in 90% of patients. So patients have to be on a high energy diet. They're taking oral pancreatic enzymes as well as insulin. But the main issue in CF that you should know about is actually respiratory, because all that fluid builds up in their lungs and they find it difficult to breathe. And then they get like recurrent infections. Splenic rupture, this is probably more of an anatomy one. So like on CT, you see this blood right here. I think that's CT. Essentially being a subcapsular hematoma, usually in your left upper quadrant, if you get some kind of blunt trauma, and then they're in like shock because they've lost so much blood, it could be a splenic rupture. And you can also get, like on the right side, you can get pain to your left shoulder because of your diaphragm and irritating that. Hepatic cirrhosis is when you're getting fibrosis of your liver. Usually it's due to alcohol or hepatitis. So in your history, ask about alcohol and ask about like IV drug use, transfusions, tattoos and stuff where the virus for hepatitis could have been spread. The major complications, like I mentioned before, are portal hypertension, but also the liver can't function enough. So you don't get good blood clotting because the liver makes all of your clotting factors apart from factors 3 and 8. And you get jaundice and you might get a buildup of toxins, which can then cause encephalopathy, which is your neurological features. The way you diagnose it is you take a biopsy, send it to path lab, and they'll show this kind of thing. So you can see the normal liver is all pretty like similar. You have these, you might do this later. I'm not sure if Kevin covered it, but they've got like these hexagonal organization with like a central vein where everything passes through. All these sinusoids go into that. And now it's like this. So it's surrounded by this fibrous tissue, and they've all been like organized or like disorganized into these lobes. Wilson's disease, just know very briefly because of your abdominal exam. It's a genetic disease which basically gives you issues with copper excretion, elimination. And the major finding you see is Kaiser-Fleischer rings like this, which is a brown ring on the iris. But they also, because copper is so toxic, they get neurological issues, they get osteopenia, and they get liver issues. And that's why you have it in your abdo exam, because it gives you like cirrhotic liver. And you treat that with a low copper diet, supplements, and a copper chelation. So that's removing the copper. Varicocele is enlargement of the pampiniform or the venous plexus in the scrotum, which drains the testes. It's usually idiopathic, but it can also be, well, I'm not sure if it's usually, but it can be idiopathic. But it's usually, it can be due to obstruction in the kidney venous drainage. And that's why it happens in the left testes more, because the left gonadal vein drains right into your left renal vein rather than right in the right side, which goes into your IVC there. And the key kind of word here is bag of worms, because you will feel it and it looks like a bag of worms. Great, cleanse skills and OSCE. How are we doing for time? Okay. Does anyone need a break? No? Okay, I'm gonna turn the light on and see what we can do. It's getting dark here. It's like 5:30. Okay. Liver function tests. This will be pretty quick, so it's all right. Liver function tests you can think of in two ways. So when you order LFTs, you get a couple of things. You get proteins, so you get bilirubin, albumin, and total protein. You also get transaminases, so ALT and AST. These things, when they go wrong, it's related to the liver itself. So it might be cirrhotic, you might have fatty liver. It's a liver issue itself. Cholestatic enzymes, like your ALP and your GGT, they're related to the bile duct. So when these things go wrong, it's like cholelithiasis, cholangitis, or anything else that's affecting that. But one thing to remember is if something's wrong with these two, something will be wrong with those two as well. So you're looking for the biggest increase. So if all four are increased, you'll usually see two that are like off the charts. This is kind of a summary. So if it's a liver issue, hepatocellular damage, ALT, AST. If it's cholestatic or a bile duct issue, then it's GGT, ALP. But then if you want to actually look at your liver function, because your LFTs don't actually measure your liver function, they're measuring hepatocellular damage and interrupted bile flow. So you'd look at these things, and all of these things are what the liver is in charge of doing. It makes thrombopoietin, so that causes production of platelets. So if your platelets decrease, your liver might have an issue. Albumin, because your liver makes albumin, might decrease if you have a liver issue. Bilirubin might increase because it's not conjugating. Or you can look at the prothrombin time. And when you do heme, you'll know a bit more about this. Essentially, it means that it's taking longer for your blood to clot. And that's because all of the clotting factors, apart from 3 and 8, are made in the liver. This is your abdominal history. It's really easy. This is a mnemonic that I didn't actually use, but it's bad anal shit. You can remember it pretty easily because it's actually related to the abdomen. So bleeding, so hematochezia, abdominal pain, dysphagia or adenophagia. Remember, dysphagia is difficulty swallowing, adenophagia is pain on swallowing, appetite or weight change, or change in fullness, nausea, vomiting, abdominal distension, bloating, ascites, lethargy and fevers, stool changes, heartburn, itch, jaundice, and travel. So travel is really important. Another way to remember it, which is how I remembered it, I found it a little easier, is I just remember top to bottom. So if you draw a little GI tract, you can think what goes in and out from top. So you can have nausea, vomiting going out. You can have change in appetite or change in weight or change in fullness going in. And then you can think, oh, okay, now I'm down to the esophagus. I'm thinking about dysphagia, adenophagia. And then I'm down to the stomach. I might think about distension. I might think about abdominal pain, heartburn, bleeding even. And then you move down a little bit more. You reach the liver. And then you're thinking jaundice, itch. And then you might move down a little bit more. And then you think like, oh, bleeding in your butt, stool changes, diarrhea, constipation. And then you think about the systemic things like lethargy, fevers, travel, things like that. This is a summary of the GI exam. I'll take you through this very quickly and explain what they all mean. This is the whole thing, so it's on one slide. But then I'll show you how to do the abdomen. And if you've got a little soft toy, I recommend you just like practice along and see how it's done. In terms of exposure, you need their top off. Usually you need their pants down a little bit because you want to see the whole abdomen. And then on general inspection, look for these 5-ish things. So think kind of top to bottom. So start with top. So mental state by the head because of hepatic encephalopathy, all those toxins building up, making them confused. Jaundice and hemochromatosis are like skin changes. So hemochromatosis is like kind of like a bronzing of the skin, whereas jaundice is yellowing. Bruising, so usually I think, oh, their face is like a different color. And then I think of bruising. So I think about like bruising on their chest, petechiae, ecchymosis, anything purpley. And that's because it's harder for the blood to clot. So you bruise more when the liver has issues. Weight, so for things like fatty liver, for things, obesity itself, I think about someone's tummy. So we're moving down again. And then I think of stretch marks and spider nevi, which are like these little, spider-like little notches, and they look a bit like a flower. These little bruises on their legs. And that's due to liver disease as well. Scratch marks because liver disease can make you itchy. Always do your vitals. Next, onto the hands. So I would do palms first, then back, then fingers, and then asterixis. And in the GI exam, there are 5 things to do on the hands plus asterixis. So I just think 5 because 5 fingers. So looking at the palms, you look for pallor, for anemia, because if you have any bleeding, it can cause anemia. You look for erythema, which is like pink, like sweaty hands. That can be due to liver disease. Look for Dupuytren's contracture, and usually that's like a little bit of like tight skin there. It makes their fingers go like this. You see this a lot in workers, but it might also be due to liver disease, alcoholism. And then look at the back. So tendons xanthomata along here, do they have any like yellow deposits on their tendons, indicating like hyperlipidemia? Look at the fingers. Do this for Shamrock's side. Do they have clubbing? 1 finger is enough. And then look at the nails. Are there any white bits on it, indicating leukonychia? And leukonychia is due to hyperalbuminemia, so lots of albumin in the blood because, hypo, I think it's hypo.
Yeah, hypoalbuminemia.
Yeah, hypo, because the liver's not producing enough. And then do your asterixis. So you'd ask the patient to lift their arms up like this and then cock their wrists back, and then hold it. And if you're not getting a very good reaction, you're still suspecting it, push their wrists back. And then it's called a flapping. I'm sure you've seen it in the rest one before, but it's a flapping tremor. So they'll kind of go like this. And that's due to liver disease. On the arms, you can look for tendons xanthomata again on the elbows, and then you can move on to their face. So for their face, I split it into like eyes, mouth, and then like their salivary glands. So for eyes, jaundice and anemia as usual, and then look for Kaiser-Fleischer rings for your Wilson's disease. In your mouth, you're looking for B12 deficiency, so glossitis, angular stomatitis. It can cause ulcers. Like I think of all the red things is what B12 deficiency causes. Halitosis, as in bad breath, can be caused by liver disease. Cyanosis, I'm not sure why you check for cyanosis in GI exam. You check for cyanosis, so bluing, central solvent cyanosis is bluing of the tongue. Leukoplakia, so you'll see like white patches at the back of their mouth, indicating infection. And take a look at the dentition as well. And then on their face, feel for their salivary glands. So you have your parotid and your submandibular glands. Your parotid are right kind of here in front of your ears. I don't know if you can see. So you kind of like feel them there. Are they enlarged at all? And then feel for the submandibular glands. So they're right under here, right under your mandible. If you massage that enough, you might realize that you start salivating a little bit. So if you know that, you've got the right place. And then move on to the neck. So look at the cervical lymph nodes. You look at these because this is where your GI system drains. And you have to know this really well. Like they should be rolling off your tongue. So do practice on like a family member or yourself. So I think 3 along the jaw first. So submental. Mental kind of means your chin. So submental right under your chin. Like that. And then submandibular over here under your mandible. Tonsillar a little bit further along. Pre and post auricular. In front of and behind your auricle or your ear. Occipital is always the back, right there. You can feel a little bit of a notch. And then your superficial and deep cervical. So your superficial cervical, you can kind of feel along here like that. Deep cervical, get them to turn their head and then dig your fingers in a little bit more. And then, I didn't write this, but posterior cervical, you can feel along the backs of their traps, and they're supraclavicular. You can get them to shrug their shoulders and then kind of dig your fingers in right here. And then that's all for the neck. So that should be really quick. On the chest, look for spider nevi and gynecomastia, both caused by liver disease. Spider nevi, more specifically, portal hypertension. And then the abdomen. So for the abdomen, first inspect. Look at the distension, look at the contour. You might be looking from the side like this. Look at the umbilicus and the veins. Look for peristalsis, whether it's visible. Look for scars, striae, stretch marks, things like that. Cullen's-Gray Turners for pancreatitis. And then we move on to the palpation. So I might stop sharing screen, see if this works. Can you see this? Is it working?
Yeah,
we can see.
Okay, so you have to split the abdomen into 9 regions like that, like I mentioned before. So you're trying to, when you're looking for superficial and deep palpation, superficial, you would literally just go to the 9 regions and press down like that until you've done them all. And you're going lightly, and you're kind of feeling for things right below the skin surface. If they have a big abdomen, you need to do more than 9. So feel a couple times with each one. And then you do deep. So deep, I got taught, basically put your hand down flat almost and flex it right here, almost like what your lumbricals would do. And you kind of go quite deep. So you're feeling for things like masses, you're feeling for things like organs, going quite deep. Like that, in all 9 regions.
Another way you can do that as well is you do like a wave, so you can go like imagine it's a surface, you can go like that around it. It's like the same thing, I think. It's like I wouldn't want to describe it.
Yeah, it really depends on who you learn it from. But make sure you do superficial and deep. And as you're going, like name it. So say, oh, this is the right hypochondrium, this is epigastric, left hypochondrium, phalanx, etc. And then you feel for the liver. So I usually go through the abdominal exam thinking, oh, what's in the abdomen? Let's just like check everything out. So when you're
just
looking
to
at
add on as well while you're doing that, so you should be looking for when they're like grimacing and stuff like that. That's like the pain and tenderness and stuff. Yeah, absolutely. And always remember to ask them if they have any pain already at the start of the exam. So for the liver, to see how big it is, kind of, you might test for hematomegaly firstly by palpating. So you get them to breathe in. Every time they breathe in, you're trying to push your like hand against it. So you say, breathe in, breathe out, and then move up a little bit. Breathe in, breathe out, and then move up a little bit. Breathe in, breathe out. And if you can, you eventually reach like their rib. But if you like kind of, if you can feel their liver, they basically probably have hepatomegaly. And then after you've palpated it and you decide, okay, I can't feel it, you might do some percussion. So percussion, you do the same way as you do with rest, kind of like that. So you hit your middle phalanx. And so you go from top down, from their chest down, like that. And then it would go from resonant to dull. When you've hit dull, you've hit the liver. You'd ask them to keep a finger there. So, oh, please keep a finger here for me. And you go from down up. And once you've hit dullness again, that's the bottom edge of their liver. And then you want that size to be less than 13 centimeters, essentially. If it's larger than that, they might have hepatomegaly. And then while you're here in the right upper quadrant, do Murphy's. So place your hand there and then just be like, breathe in. If they catch their breath, then that's Murphy's positive. Given you did it on the left as well and they didn't catch their breath. Next, look for the spleen. So you've done the liver, you've done the gallbladder, now do the spleen.
So same thing, you're trying to test for splenomegaly, and splenomegaly can get huge. It can literally reach like all the way over here. So you have to start from this right iliac fossa, and then you, same thing, breathe in, and while they're breathing in, you're pushing forward. So breathe in, breathe in, breathe in, and then if you can't feel it, you're like, oh, great. And then what you might do is you might do shifting dullness. So shifting dullness is a sign for ascites, and essentially you start from the top and you're percussing all the way to the side, and it should stay resonant. If it goes from resonant to dull, usually kind of down here, that's because you hit fluid, and fluid means they've got ascites. So if they've got ascites, or it could be a mass. So after that, to test if it's ascites, you get them to turn over, keeping your finger there, wait 30 seconds, and then percuss it again. If it's still dull, it's a mass. If it goes resonant, then all that fluid has moved down, and hence it's ascites. And then while they're on their side, I would percuss again here for Castle's triangle, and that's kind of in your last like 2 ribs-ish, again for splenomegaly if that's dull.
For ascites in like an OSCE setting, you can just say you're gonna like wait 30 seconds. They'll let you like pass without actually standing there for 30 seconds, because that'd be a waste of time.
Yeah, and actually try to listen for these. If you get it wrong, they're not gonna like penalize you that much. You're like a second year, right? So like give it a go. Try to see if you can hear anything. Next, you've done the liver, you've done the gallbladder, you've done the spleen, you've done shifting dullness. Now you kind of think midline. So I might blot the kidneys now. So the kidneys, think kind of by the umbilicus-ish. You put one hand here and then one hand underneath, really close to the spine almost, because that's where your kidneys are, kind of just below the ribs, and then really quite close to the spine. And then if I take my hands out, just pretending they're still there, what you're doing is essentially you're kind of pushing them up like that. And that's why they're called blotting. And what you're trying to do is essentially you're trying to like push the kidneys up really quickly so it hits your upper hand. And if you can feel it, that's great. They might have polycystic kidney disease, they might have something else making the kidneys big, or they might just be really thin. So it might be normal if it's a really thin patient. It might not be normal as well. And then on the other side, you would kind of do the same thing like that. And then you thought about the kidney, so think about where it leads. It leads to the bladder. I might check the bladder. Is it too full? Percussive, suprapubic. That's it. And then while you're down here, think about what's right next to it. So the appendix. Appendix, you can check McBurney's point. So I press down 2/3 of the distance from the umbilicus to the aces, right there. If it hurts, it could be check rebound tenderness, so pressing down and then releasing quickly. Is it painful? Check for Rovsings, so pressing over here and getting pain over here. And then I would skip the obturator and the psoas sign because it's not in the GI exam. And then you can palpate for the aorta. So like this, pressing really deep, and then you'll actually feel like a pulse. And then you try to keep moving your fingers out until you've like measured how big the aorta is. Next, you'll do some auscultation. So I must step here. Not that you're going to hear anything. But you use the diaphragm for everything. You can listen for bowel sounds anywhere. Just literally put it down, wait a couple seconds, and you're hoping to hear something. I think within 30 seconds. And if they're not, you're suspecting something like paralytic ileus. Like they're not peristalsing, basically. And then you can listen for aortic bruits by like kind of just above or below the umbilicus, and then renal bruits just on either side of the umbilicus. And then check the back and legs for edema. Does that make sense? Has anyone got any questions?
As an extra comment, to save a little bit of time, you kind of inadvertently do a lot of the tests while you're palpating. So when you're palpating up towards the liver, you kind of do McBurney's point anyway, because you get them to breathe in order to push up to the liver. So I would just palpate up to the liver, wait, get them to breathe in, and then say, well, McBurney's is also negative. And then in terms of like, Murphy's. And then in terms of McBurney's point and Rovsing's sign, again, you kind of inadvertently do it when you're palpating in the iliac regions. So if you're doing all of your 9 regions properly while you're palpating, you can just mention McBurney's point, there's no tenderness, and also there's no Rovsing sign, there's no cross tenderness there. And that just saves you a little bit of time rather than having to go back and do it again.
Yeah, absolutely. And likely if you guys even have OSCEs this year, they won't make you do the whole exam. So they might be like, oh, check all the peripheral signs for the GI exam. Or they might say, oh, just do the abdomen part of the abdo exam. Alrighty, back to sharing screen. We're almost done. So this is a bit more information on everything. After your exam, you want to say, oh, a complete examination also requires hernial orifices and testes and a PI exam, basically. But you don't learn that yet. And these are some details on what you need to do. Other than that, you can have an OSCE, if you have OSCEs, on an obesity assessment. So if they ask you to take a history, make sure you talk about weight, their current weight, whether it's changed, whether they've ever been another weight and that's changed recently. Previous attempts at weight loss, when it was, how successful, did they get professional help? Diet, so you need quite a detailed diet history. Yesterday in detail, include drinks, dietary restrictions, and then assess physical activity over a week. And then ask about like your usual history, so any medical problems, specific diagnoses, medications, family and social history. And then on examination, these are the main things you need to do. So for BMI, weight over height squared, like before, waist to hip ratio. So hip is the widest part around your buttocks, and waist is the midpoint between the costal margin, so the bottom of your ribs, and your iliac crest, so the top of your hips. And then your waist circumference, again, taken from your waist. Great, so that is it for this session. How do I, here. Do we have any questions? I reckon not. And how are we feeling about, I might stop the recording actually.